Thank you. My name is Joep van Oosterhout, and I'm presenting performance of different models of care when initiating lifelong ART for pregnant women in Malawi. I'm presenting on behalf of the first author who was unable to make it to this conference. Our study was a collaboration between Dignitas International, the Malawi Ministry of Health, and the International Union Against Tuberculosis and Lung Disease. In Malawi, the new PMTCT strategy of Option B Plus was introduced in 2011, and it entailed that pregnant and breastfeeding women started lifelong ART irrespective of their clinical situation and their CD4 count. The strategy was subsequently implemented in other countries and now also forms part of WHO guidelines. However, there was no formal evidence base for the strategy, and some concerns were expressed about the potential to losses to follow-up and the spread of drug resistance. When Option B Plus was introduced in Malawi in 2011, there were no guidelines for integrating it into the routine service. So health facilities had to consider different approaches for the location and timing of ART, adherence counseling, and the follow-up after delivery or breastfeeding. It was uncertain for them where the choices they would make would affect uptake, adherence, and retention on ART. When the strategy was introduced in Malawi, we saw an enormous increase in the number of breastfeeding and pregnant women starting ART, as this report from Chibandira and others in 2011 clearly demonstrated. Another study published in 2014, providing nationwide health facility level data, showed that the 6-month retention rate was 83%, but there was great variation between health facilities, varying as much as between 100 and 42% of retention on ART. Clearly, more insight is required into the factors that determine uptake and, in particular, retention on ART. So, therefore, we did a study with the following aims. We wanted to describe the diversity of approaches to service organization that we call models of care for the delivery of Option B Plus to pregnant women in health facilities in Malawi. Second, we wanted to explore associations between the model of care that we found and program indicators at health facilities, for instance, uptake of HIV testing in antenatal care and uptake of ART and retention on ART. The study took place in the southeast health zone of Malawi, an area that contains 6 out of the 28 districts in the country, and where there are around 3.5 million inhabitants. Integrated HIV care services take place in 153 health facilities out of 588 facilities nationwide. Around 154 pregnancies take place every year, of whom close to 15% take place in HIV-infected women. Methods. We did a cross-sectional health facility survey using structured questionnaires to obtain per health facility information of staffing, ART initiation location, adherence counseling, follow-up and transfer, in order to identify the so-called model of care. We used routinely collected health facility cohort reports to ascertain the uptake of HIV testing and the uptake of ART initiation in pregnant women in antenatal care, as well as cohort survival outcome data for the evaluation of 6-month treatment outcomes in women who had registered as having started ART under Option B Plus. Thirdly, We wanted to explore associations between the identified models of care and 1, the uptake of HIV testing and ART among pregnant women, and 2, 6-month treatment outcomes, using descriptive analysis and logistic regression models. For these analyses, we took definitions of high HIV testing uptake more or less arbitrarily of larger than 85%, and we defined high retention on ART as more than 92%. This was the upper level of the interquartile range that we found. 141 out of 153 health facilities were included in our study, of which 4 were district hospitals, 8 were community hospitals, 120 health centers, and 9 private clinics. And it should come to no surprise that there were major differences in terms of staffing between these different health facility types, as well as between the number of women newly registered for antenatal care per quarter, and the number of newly registered starting ART under option B+. So we identified 4 different models of care. Model A, where facilities where women are initiated and followed on ART at the antenatal care clinic until giving birth, and there were 75 of such facilities. Model B were facilities where women receive only the first dose of ART at the antenatal care clinic and are then transferred and followed up at the ART clinic, and there were 38 of such facilities. Model C were facilities where women are referred from the antenatal care clinic to the ART clinic for both ART initiation and follow-up. There were 18 of such. And Model D were facilities that actually did not provide antenatal care, but only served as ART referral site. And those were the minority, and there were 9. Bear with me for this rather busy slide. It wants to show that within the 4 different models of care identified, there was further variation in terms of the timing and place of adherence counseling for ART initiation, as well as for the timing and transfer to ART and/or mother-infant pair clinics. Sorry. So here we see health facility variables associated with high HIV testing uptake at antenatal care. Remember, defined as larger than 85%. Health facility variables that were not associated with high HIV testing uptake at antenatal care were district location, client to clinical staff ratio, the health facility type, and the number registered in antenatal care. Health facilities that were associated with high HIV testing uptake were a low client to HIV testing staff ratio, a low number of out-of-stock observations of HIV test kits, and the model of care applied, where health facilities in Model A had a 3.4 times higher likelihood to achieving high HIV testing uptake than health facilities in Model B. Here we see health facility variables associated with high 6-month retention results of multivariable analysis. Health facility variables that were not associated with high 6-month retention were health facility type, client to clinical staff ratio, timing of adherence counseling, the availability of ART/PMTCT services, whether daily or not daily availability, and the availability of ART/mother-infant pair clinics for follow-up. Health facility variables that were associated with high 6-month retention were the district location, a low number of women in the option B plus cohort, and the model of care applied by the health facility, where health facilities in model C had a 5.4 higher likelihood of achieving high 6-month retention in comparison with health facilities in model B. So, discussion. We found that 18 to 32% of pregnant women were not tested for HIV at antenatal care, and that HIV testing uptake was associated with client to HIV testing staff ratio, test kit stockouts, and the model of care applied by the health facility. We also observed that 7 to 20% of the women defaulted option B plus by 6 months, and that retention was associated with district location, patient volume, and the model of care applied in the health facility. We observed that worst program indicators were seen in model B. That is where health facilities where women receive only the first dose of ART at the antenatal care clinic and are there and then are transferred for further follow-up on ART at the ART clinic. So we need to consider strengths and limitations of our operational research study. This was an example of operational research utilizing high-quality routine government data, allowing us to present real-world findings about option B plus implementation. Another strength was that we used a large data set of 141 health facilities. Limitations of the study also need to be considered. Results may not have been representative for the whole of Malawi. We studied only health facility level data and not individual patient level data. And of course, the cross-sectional study design has some limitations, in particular the potential for residual confounding, even if we used multivariable logistic regression analysis. Lastly, we did not study attrition due to linkage of care, and in particular that could be relevant for the models of care C and D. So, in conclusion, we have described varieties in the way health facilities have integrated option B plus care into the routine service delivery. We identified 4 different models of care and found that they were associated with the uptake of HIV testing in antenatal care clinics and with the retention in care on antiretroviral therapy. We feel that further research is required to guide policy recommendation, in particular patient-level, individual-level research. Thank you for your attention, and I would like to acknowledge USAID and the International Union Against TB and Lung Disease for funding, as well as Dignitas International Medical Programs, monitoring and evaluation program, and the data departments for their help with the study. Thank you very much.
That was a great presentation, Chip. I'm Colin Spate from Lighthouse in Malawi. I think you identified, it was a really good presentation. I think you identified one of the limitations, which was the lack of analysis of the attrition between referral to C and D. And I think hidden in the odds ratio of 5.4 for high retention is probably one of the most critical aspects, in that if a woman is started on ART on the day, there'll be very, very high rates of initiation. If she then has to go to another clinic to continue, but she's already started, then women who have no intention of taking ART for whatever reason will be lost. They'll disappear. So you'll appear to have very low retention rates. At facility C, where you're only getting women that are basically saying, I'm going to take ART. So they're coming back. You've got a much smaller denominator, or significantly smaller denominator, that are far more motivated to take ART. So inevitably, you're going to have a much, much higher retention. And I think I've made this point before. If you have one facility with 100% initiation, but only 80% retention, that is exactly the same as a place with 80% initiation and 100% retention. But if you're only looking at the retention aspect, one looks a lot better than the other, but they're really much the same.
Yeah. Thank you for that comment, Colin.
We'll turn to 4. We'll ask people to limit their questions to brief questions. Hopefully we'll have time for discussion later.
Okay, I'm Colin. I'm also working in Malawi with partners in HOP. Thanks also for a great presentation. And I think somewhat findings were a little bit contrary to sort of what we wanted or what expected even, as the government really was pushing for the Model A in care. There was 2 things I was interested in. I'm assuming that like your program, similar to our program, is done on the back of a mentoring program where the sort of part of the aims is actually to move sites towards the Model A, because part of the trainings when the guidelines were introduced in 2011, it certainly was recommended by the Ministry of Health that all sites should be providing Model A. So I was wondering how much sort of interference went on in the process of collecting this data, either in terms of your team trying to actively move sites to Model A, or whether sites in time by themselves moving to Model A because of pressure and recommendations from the Ministry of Health.
Yeah. Yeah, no, there was no pressure from Ministry of Health or even from our side to force health facilities using one model or the other.
Another question at 4.
Yeah, my name is Esther from Zimbabwe. I have a very quick clarification question. For facility level B, when you say first dose, are you literally saying 1 tablet, or are you saying first month of treatment?
No, we are saying first dose.
Number 1.
Thank you very much for sharing these results. I'm Ruben from Zimbabwe. I just want to make a comment on your finding around, association between district and retention, which I assume you are saying clients that were initiated at district hospitals were likely to be retained in the program. I do think if you communicate your finding that way, you may not be bringing out the point. It might be that, what you are seeing being associated with retention is initiation and follow-up within the same health facility, rather than a district hospital per se. Because findings elsewhere, I think, do indicate that clients who are initiated in ANC in district hospitals, who sometimes are referred from peripheral clinics, they are less likely to be retained because of the distance over which they are referred. So I think the way you are presenting your finding might be hiding the important factor that you found in your study. Thank you.
Well, maybe I could just say that district location was one of the variables that was taken into a multivariable analysis. So those findings would be independent from the other variables that were presented in our study. I hope that answers your question.
Just before we move on to the next speaker, from the data you presented, one could say, well, integrated care doesn't work. Obviously, as you outline a number of limitations and caution around making that interpretation, but did you look at all at the other health outcomes for the mother or the child besides ART retention?
We did not. But there are large studies in country underway that are going to address those pieces of information. And we are also involved in those studies. But I agree that is also one of the limitations of our study. Yeah, thank you.
Thank you. Excellent.